Welcome back to the deep dive. Our mission here is, as always, to take some really dense, high-stakes material and, well, make it stick.
Exactly. And today we're diving deep into the fundamentals of respiratory medicine.
We're pulling from Davidson's Medicine, Chapter 17, and really focusing on those key conceptual anchors.
Right. We know that as a learner, you're trying to build that solid clinical foundation, and that means going way beyond just rote memorization.
It has to be about conceptual clarity, doesn't it?
It has to be.
Yeah.
We want to give you the mental scaffolding to, interpret symptoms, recognize the big differentiators when a patient actually walks in the door.
Building that mental architecture. And we should probably just acknowledge the sheer scale of what we're talking about here.
Oh, it's vast.
Respiratory pathology covers everything. Infectious diseases, inflammatory conditions, cancer, chronic degenerative states. It's huge.
It really is a field of contrasts, and our sources really highlight this. You have genuine, amazing progress in some of the obstructive diseases.
Like COPD, CF.
COPD, cystic fibrosis, obstructive sleep apnea for sure. Targeted therapies have really changed the outlook for so many patients there.
But on the other hand,
and it's a big but, we have to face the sobering reality that for things like aggressive lung cancers or some of these interstitial lung diseases, the outcomes are still profoundly poor.
so it's an area where those early diagnostic skills, the stuff we're talking about today, can quite literally make the difference.
The difference between a manageable disease course and, a rapidly fatal one.
Okay, so let's start where the workup almost always starts, with the symptoms.
Mm-hmm.
Our first conceptual anchor has to be the cough. I always think of it as the body's airway alarm system.
That's a great way to put it. And like any alarm system, the first thing you have to do is figure out if it's a false alarm or a genuine threat.
Right.
So for you, the early learner, the crucial split is acute versus chronic. An acute cough, less than 3 weeks, is overwhelmingly common and usually pretty benign.
We're talking a virus, a bit of postnasal drip, maybe some transient aspiration.
Exactly.
Yeah.
But the real clinical challenge, the diagnostics sinkhole, if you will, is that chronic cough.
The one that's been there for 8 weeks or more.
Yes. Where the patient is frustrated, they've probably been misdiagnosed a few times. And this is where we have to be disciplined, and this is key, look outside the lungs first.
Okay, so you're saying don't jump straight to a chest x-ray.
Absolutely not. You have to anchor what we call the 3 great extrathoracic imposters.
The imposters, I like that.
Because statistically, these non-pulmonary causes are so incredibly common that you risk a completely unnecessary, expensive, and sometimes invasive workup if you don't screen for them first, right in the history.
Okay, let's nail them down. Imposter number 1.
Post-nasal drip, usually secondary to some kind of nasal or sinus disease.
And this gives you that classic throat clearing sensation, right, where the back of the throat is just constantly irritated.
That's the one. Okay, imposter number 2 is gastroesophageal reflux disease, GORD.
Now, this one can be tricky because it can be silent. The patient doesn't always have that classic heartburn.
Precisely. The refluxate, the stomach acid, causes the cough either through tiny, tiny amounts being aspirated into the larynx or trachea,
Microaspiration.
or through a vagal nerve reflex that actually starts way down in the distal esophagus. So the patient feels nothing, but the nerve's being triggered.
Okay, and imposter number 3. This is the one that's on every exam, every clinical rotation.
Angiotensin-converting enzyme inhibitors. The ACE inhibitors.
Those are classic.
It is a high-yield memory hook for a reason. ACE inhibitors, they interfere with the breakdown of something called bradykinin in the lungs.
So it builds up.
It accumulates, it irritates the airway nerves, and that triggers this chronic, typically very dry cough.
This detail is more than just academic, though. Why is the clinical timeline of an ACE inhibitor cough so important for the learner to grasp?
Because of what happens if you miss it. If you don't get that drug history, or if you assume it's something else, you could put that patient through months of unnecessary inhaled steroids, spirometry, chest x-rays.
Or maybe even a CT or a bronchoscopy?
All of it. And here's the timeline that saves you from all that. The sources warn that the cough can take up to 6 months, that's half a year, to fully go away after you stop the medication.
Wow, 6 months.
If you don't wait that long, you'll falsely conclude the drug wasn't the cause and keep looking. That clinical patience is just so crucial.
That really underscores the importance of a good history. You can save the patient time, money, radiation, everything. Okay, let's flip the switch. When does the cough signal a pulmonary emergency?
It's all about context. When you combine it with exposure or other signs. So an adult patient with a chronic cough and a significant tobacco history.
Your alarm bells should be ringing.
Immediately,
Yeah.
you're thinking lung cancer. If their chest x-ray is abnormal, a new mass, some collapse, you escalate straight to a CT scan.
But what if the chest x-ray is normal?
Even then, if the x-ray is normal but they have other red flags like unexplained weight loss or some blood streaking in their sputum, you have to proceed to CT.
You can't be falsely reassured by a clear x-ray.
You absolutely cannot.
And here's a really specific anchor from the physical exam, one that brings us right back into the lung tissue itself. A dry cough paired with fine inspiratory crackles.
Yes. That combination should immediately make you think of and investigate for interstitial lung disease, particularly idiopathic pulmonary fibrosis. That specific sound, that symptom, it's a massive clinical red flag for fibrosis.
So let's tie this back to your metaphor. The cough is the doorbell ringing over and over.
Yeah, right. So we ask, is the problem at the door, the pharynx or larynx?
Oh, it's a nasal drip.
Is it coming from the basement, the GRD reflex?
Or is the wiring itself just faulty, that ACE inhibitor side effect?
And only after you've ruled out those 3 non-pulmonary causes do you really start to focus on the inside of the house, the lungs themselves.
So the key takeaway here is that when you're working up a chronic cough, you must systematically rule out postnasal drip, GRD, and ACE inhibitors before you go down that long, complex road of lung-focused tests.
Absolutely.
All right, time for a quick check-in. This is really fundamental stuff.
Let's see if you've got it.
Check-in question. If a patient develops a persistent, non-productive cough 4 weeks after starting a new medication for hypertension, and their physical exam is completely normal, which common drug class should you immediately suspect?
And as a follow-up, if your suspicion is right, how long might you tell the patient that symptom could last even after they stop the drug?
Think critically about the drug class and that very specific timeline we mentioned.
If that 6-month figure isn't coming to mind, just rewind a minute and really lock it in. It's a crucial piece of advice.
Okay, let's move on to the symptom that really incapacitates patients. Breathlessness, dyspnoea.
The sources define this as the subjective sensation of an uncomfortable need to breathe. And what's so fascinating is that it's a feeling, a subjective one, without a single specific receptor for breathlessness, yet it's intensely real for the patient.
Intensely real. And it's driven by a complex integration of signals.
Right. Our pathophysiology anchor here should be the stimuli network. Dyspnoea is what happens when your central nervous system just sums up all these inputs from different sources, all of them converging on the respiratory centers in the brainstem.
And based on the sources, we can really break down the stimuli into 3 main categories. First up is mechanical irritation.
Exactly. Mechanical irritation or stimulation of the interpulmonary sensory nerves. Think about a pneumothorax, a collapsed lung.
Okay.
The lung collapses. It violently stretches the nerves in the pleura and the remaining lung tissue, and that triggers this immediate, profound sense of dyspnoea.
A pulmonary embolism would do that too.
Yes, the PE causes irritation from ischemia and inflammation just beyond the blockage. These are sharp, acute stimuli.
Okay, so the second category is a massive increase in mechanical load. This is where the actual physics of breathing just become incredibly difficult.
And this happens in 2 main ways. You can have airflow obstruction, like in asthma or COPD, which makes breathing out a long, strenuous fight against resistance. Or you have a restrictive defect, like pulmonary fibrosis, where the lung is just stiff and scarred. It requires huge muscular effort just to expand the chest.
And the third way is chemical stimulation.
Right. Hypoxia, hypercapnia, acidosis, they're all stimulating the chemoreceptors in your body. It's basically the brain screaming, the blood quality is bad, breathe faster.
And heart failure feeds into this as well.
It does, because a poor cardiac output leads to early muscle fatigue, lactic acidosis, and that just further stimulates those same chemoreceptors.
So when you're taking the history, you have to use the timing and the variability of the dyspnoea to start telling things apart.
Absolutely crucial differentiators.
Variability for me is the anchor for asthma.
Yes. The symptoms come and go. They're episodic, often tied to specific triggers like allergens or cold air, and characteristically they happen at night or in the early morning, often waking the patient up.
You contrast that with COPD.
With COPD, the breathlessness is just gradual and relentless. It's a progressive loss of exercise capacity over many months, many years, leading to a really consistent, predictable level of disability day after day.
Now let's talk about a potential clinical trap for the learner. Orthopnoea, breathlessness when lying flat.
Yes.
We're all taught this is a hallmark of heart failure, But the source material warns us it is not a reliable differentiator.
You have to be so careful with this one. While it is very common in left-sided heart failure, because when you lie down, blood volume redistributes and causes congestion in the lungs, it also happens in severe COPD.
But for a different reason.
A completely different mechanism, but clinically just as real. In severe COPD, the diaphragm is low and flat. When the patient lies down, the abdominal organs push that already compromised diaphragm up cranially, worsening the mechanical disadvantage and causing more airflow obstruction.
So if a patient says they have orthopnoea, you have to think about cardiac and pulmonary causes equally. Okay, finally, let's touch on the symptoms that look neurological but actually start with breathing pattern disorders.
Right, often what we call psychogenic hyperventilation. And the presentation is often strikingly uniform.
The patient will say something like, I just can't get a deep enough breath in.
That's the classic complaint. Or they'll describe these strange neurological feelings. Lightheadedness, tingling around the mouth, perioral paresthesia, chest tightness, and sometimes even a true carpopedal spasm.
That spasm is the conceptual anchor here. Why does rapid, shallow breathing cause those neurological symptoms? What's the link?
It all comes down to the chemistry. Hyperventilation rapidly blows off too much CO2, so your PaCO2 level drops. This drop causes an acute respiratory alkalosis. The pH of your blood rises.
And that pH shift is the key.
That rapid shift in pH has a profound effect on how calcium binds to proteins in the blood. It effectively reduces the amount of free ionized calcium, which in turn leads to neuromuscular excitability and eventually those muscle spasms in the hands and feet.
And if you recognize that link, it points you straight to the diagnosis.
Exactly. And crucially, these episodes, they almost never disturb sleep, they happen at rest, and they're often triggered by stress or anxiety.
So the key takeaway for dyspnoea is that even though it's subjective, it's rooted in very clear physiology. You look for variability for asthma versus progression for COPD. And if you see neurological symptoms, you link them back to that acute respiratory alkalosis and think about a breathing pattern disorder.
But always remember, pleuritic chest pain in a breathless patient means you have to rule out a pulmonary embolism first. That's a must.
Let's move to the non-negotiable red flags. The symptoms that just demand urgency and a high suspicion of cancer.
Okay.
Hemoptysis, coughing up blood.
Has to be treated as serious until proven otherwise. No exceptions. Even just small episodes, a bit of blood streaking in the sputum, that should trigger intense concern, especially for a malignancy.
And the history really dictates how urgent it is.
It does. Small recurrent blood streaks are highly suggestive of lung cancer. But acute, massive hemoptysis, that can be immediately life-threatening.
So what do you do?
Immediate resuscitation. You nurse the patient on the side of the bleeding lung, if you know which one it is, to protect the other airway. And often you need emergent procedures like a rigid bronchoscopy or bronchial artery embolization to stop the bleeding.
Okay, now for our most potent physical examination anchor, the one you absolutely cannot afford to miss.
Digital clubbing.
This is the loss of that normal angle between the nail bed and the skin, right?
Right, the nail margin gets displaced upwards. This sign is a biological siren. Something like 80% of acquired clubbing cases are thoracic in origin.
So we're talking about really serious pathology.
Yes. Lung cancer, chronic suppurative conditions like bronchiectasis or pulmonary fibrosis.
And here is the fact that everyone listening needs to carve into their memory. Clubbing is never associated with uncomplicated chronic obstructive pulmonary disease.
This is such a critical point of differentiation. If you're examining a patient you know has COPD, you find clubbing, you must immediately suspect something else is going on.
Like what?
A secondary process, most likely an underlying lung cancer, which is very common in that population, or maybe complex bronchiectasis. You cannot, under any circumstances, just dismiss it as part of the COPD.
Okay, so the key takeaway is non-negotiable. Clubbing is a critical physical sign. If you see it, you have to launch a thorough and immediate investigation for cancer or a serious chronic infection.
Absolutely.
All right, another check-in question. A 68-year-old heavy smoker with a 20-year history of known COPD comes in for a routine review. On examination, you notice clubbing.
Given that clubbing is never associated with uncomplicated COPD, what is the single most urgent diagnostic step you must now take?
Your first thought here needs to focus on the absolute worst-case scenario that shares that smoking history.
If your answer is something like reevaluate their COPD status, you've missed the giant red flag we just talked about. Rewind and listen again.
Okay, let's pivot now to the two massive conditions that plague the distal airways: asthma and COPD.
Right. They both cause obstruction, a reduced ability to get air out, but their mechanisms and how we treat them are worlds apart.
So let's start with how we actually define that obstruction.
It begins and ends with spirometry. That's the gatekeeper. The gold standard definition of airflow obstruction relies on two things happening at the same time.
Okay.
A reduced forced expiratory volume in 1 second, the FEV1, and critically, a reduced ratio of FEV1 to forced vital capacity, the FVC.
Why is that ratio so important? Why not just the FEV1 by itself?
Because your FEV1 could be low just because you have small lungs, which would be a restrictive defect, not an obstructive
Or
one.
you're just not putting in a good effort.
Exactly. The FEV1-FVC ratio is the anchor for obstruction because it specifically compares how much air you can force out in that first second relative to the total amount of air you can force out. If that ratio is low, it means air is getting trapped. It's the universal marker of trapped air.
And the key difference between asthma and COPD is reversibility versus persistence.
That's the core concept. Asthma is defined by airway hyperreactivity, or AHR. This leads to obstruction that is variable and, crucially, often reversible.
And we test that reversibility.
We do. We demonstrate it by showing a significant increase in FEV1 after the patient uses a bronchodilator. And to be significant, it has to be an increase of 12% or more ND 200 milliliters. You need both the percentage and the absolute volume.
COPD, on the other hand, is all about persistent, irreversible airflow limitation.
Right. The standard diagnostic threshold is a post-bronchodilator FEV1-FEC ratio of less than 0.7. The damage is fixed. It's not going to reverse.
So let's use that analogy, Anchor, to really solidify this.
Yep.
Asthma is like a twitchy, hyperreactive door. It sticks when it's humid or the wind changes, but you can kick it open with medication. It's reversible.
Whereas COPD is a door frame that has been so warped by decades of smoke damage, emphysema, fibrosis, that the restriction is permanent. It's a fixed limitation.
That's a great way to picture it. Okay, let's dive a little deeper into asthma, the twitchy airway.
The pathophysiology of the allergic response is, well, it's beautifully and troublingly biphasic. You get an early reaction and a late reaction.
The early reaction is immediate.
Right. Mediated by the rapid release of things like histamine from mast cells. It causes smooth muscle contraction, bronchospasm. This is what your rescue inhaler, your short-acting beta agonist, targets.
But the late reaction is where the real danger is. It happens hours later.
And this phase is purely inflammatory. It involves the recruitment of inflammatory cells, eosinophils, T lymphocytes, which cause that persistent damage and hyperreactivity.
And that's why inhaled glucocorticoids, or ICS, are the absolute backbone of long-term asthma treatment.
Exactly. They don't do much for that immediate spasm, but they target the late phase, that core inflammation. That's what we're trying to prevent with controller medications.
Beyond spirometry, how do we nail down the diagnosis?
It requires some nuance. Serial peak expiratory flow, or PEF, monitoring is really important. It helps detect that variability in that characteristic morning dip, where the PEF falls sharply overnight.
And we should probably talk about exhaled nitric oxide, FeNO.
We should. For the modern learner, this is a key test. An elevated FeNO, specifically greater than 50 parts per billion in adults, is a very helpful marker.
Why? What does it tell us?
Because it strongly supports a diagnosis of eosinophilic asthma. And that's an inflammatory subtype that we know is highly likely to respond really well to inhaled glucocorticoids.
Okay, let's talk management logic. It's all about that stepwise approach, isn't it?
It is. The goal is to achieve and maintain control, which means minimizing daytime symptoms, nighttime awakenings, and the need for a rescue inhaler.
Step one is the preventer, a low-dose ICS.
Right. If that's not enough to get control, we move to step 2, which is adding a long-acting beta agonist, a LABA.
And this is where we hit a critical safety rule. The LABA should always be added in a fixed-dose combination inhaler with the ICS. Why is LABA monotherapy, just the LABA alone, so dangerous?
Because the LABA treats the symptom, the bronchospasm, without treating the underlying disease, which is the inflammation.
So you feel better, but you're actually getting worse.
Precisely. If a patient relies only on the LABA, they are masking the severity of their worsening inflammation, and that can lead to catastrophic sudden exacerbations. Large studies have linked it to an increased risk of asthma-related death.
So the ICS must always be on board to treat that inflammatory late phase.
Always. And some of these combination inhalers, particularly those with the fast-acting LABA formoterol, can be used as what we call MART.
Maintenance and reliever therapy.
Yes. The patient uses the same inhaler for both their daily maintenance dose and for as-needed relief. It effectively lets them auto-titrate their steroid dose in response to their symptoms.
And beyond step 2, the management just keeps stepping up.
It does. Increasing the ICS dose, maybe adding a leukotriene receptor antagonist or a LAMA. And then for the really severe refractory cases, we have specialist biologic therapies that target things like IgE or IL-5.
One last point on asthma before we move on. Pregnancy.
Ah, yes. The source material is very reassuring here. The bottom line is well-controlled asthma leads to good outcomes.
And uncontrolled asthma.
Uncontrolled asthma significantly raises risks for both the mother and the fetus. The data we have confirms that the standard medications beta agonists, ICS, are safe and absolutely should not be withheld out of fear.
Good to know. Okay, time for another check-in question.
Yeah.
A patient with asthma is currently using a low-dose inhaled glucocorticoid, but is still reporting frequent nighttime symptoms. You're moving them to the next step of therapy. Which additional drug class must you add?
And more importantly, what is the critical safety rule about how those two drugs must be prescribed together?
Remember that principle. Treat the spasm and the inflammation. The answer is all about preventing that life-threatening masking of the disease's severity.
All right, let's go to the other side of the obstruction coin. Chronic obstructive pulmonary disease, COPD.
The fixed limitation. This is that persistent, irreversible airflow limitation caused by damage to the airways and the alveoli.
And the main culprit is noxious particles. In the UK, that means tobacco smoke in about 95% of cases.
The pathology is a mix of two things, isn't it? Chronic bronchitis and emphysema.
Right. Chronic bronchitis is the clinical definition, persistent cough and sputum. Emphysema is the physical destruction and permanent enlargement of the air spaces themselves.
Let's hit the most crucial anchor for prognosis. This is the single non-negotiable fact for every COPD patient you will ever meet.
Sustained smoking cessation is the only strategy that favorably impacts the natural history of the disease.
Nothing else.
Nothing else slows that inexorable year-on-year decline of FEV1 down to near normal rates. Bronchodilators, they improve quality of life, they reduce exacerbations, but only stopping smoking actually halts the physical destruction and changes the long-term mortality curve.
Since we can't reverse the damage, the management goals have to be different.
They are. We focus on improving breathlessness and reducing the frequency of those potentially fatal exacerbations.
So pharmacologically, what's the cornerstone?
Long-acting bronchodilators, the LABAs and the LAMAs. Dual therapy with both a LABA and a LAMA is often standard practice for symptomatic patients.
And what about inhaled glucocorticoids? They're central in asthma, but what about here?
They play a much less central role. They are generally only added in severe disease, often as part of what we call triple therapy LABA, LAMA, and ICS.
But there's a trade-off.
There's a significant trade-off. While triple therapy can reduce exacerbations, it also significantly increases the risk of pneumonia, especially in older or more fragile patients. You're always balancing relief against that infection risk.
We also have to talk about long-term domiciliary oxygen therapy, LTOT.
This is a life-extending treatment, but, and this is a big but, only for a very select, severely hypoxemic group. The criteria are strict.
What are they?
The sources are clear. LTOT improves survival only in patients with severe chronic hypoxemia, specifically a resting PO2 of less than 7.3 kPa. Or those who are between 7.3 and 8 kPa, but also have complications like peripheral edema or established pulmonary hypertension, what we call cor pulmonale.
And how they use it is crucial.
It's everything. It has to be used for a minimum of 15 hours a day to get any meaningful survival benefit. The goal is to raise the PaO2 above 8 kPa. If the patient just uses it as needed or for a few hours in the evening, they get zero mortality benefit.
And finally, let's revisit the fact that COPD isn't just a lung disease.
It's so systemic. It causes muscular weakness, weight loss, osteoporosis, and that development of right heart failure, cor pulmonale.
We mentioned the edema earlier. The pitting edema you see in advanced COPD isn't always from left-sided heart failure, is it?
Often it's not. It's secondary to salt and water retention, which is caused by renal hypoxia and hypercapnia. The kidneys get poorly oxygenated blood. They respond by holding onto fluid, which makes the right ventricle work even harder against those high pulmonary pressures. It's a systemic domino effect.
Okay, so what happens when that chronic fixed limitation suddenly destabilizes? We face acute respiratory failure.
And here, interpreting arterial blood gases, ABGs, is completely non-negotiable. You have to anchor the difference between type I and type 2.
Type I, respiratory failure. That's a failure of oxygenation.
Correct. The ABGs will show a low PO2, but with a normal or even low PO2. This is primarily a ventilation-perfusion mismatch, a VQ mismatch.
So air is getting to a part of the lung that isn't getting blood flow, or blood is flowing to a part of the lung that isn't getting air.
Exactly. Think of type I as a perfusion or a gas exchange problem. Classic examples are a pulmonary embolism or pneumonia.
And management is usually about giving oxygen.
Right. Titrate oxygen carefully to get their saturation up to a target of 94 to 98%.
Okay, so type 2 respiratory failure. This is a failure of ventilation.
Yes, the ABGs here show a low PaO2 but with a high PaGO2. This means the body simply cannot move air in and out fast enough to clear the CO2 it's producing.
So this is more of a pump or muscle failure problem.
That's a great way to think of it. Severe COPD exacerbations, advanced asthma, neuromuscular diseases, they all lead to this. And the rising CO2 causes acidemia, which is a medical emergency.
The most dangerous situation is that acute on chronic COPD crisis.
It is. These patients have chronically high CO2, but their kidneys have compensated by retaining bicarbonate to keep the pH normal. When they get sick, that compensation fails, they become acidemic, and they're at risk of CO2 narcosis.
Which brings us to arguably the most vital safety anchor in all of respiratory medicine, the hypoxic drive. Why do we have to be so careful with oxygen in these type 2 patients, and what is our target saturation?
Because decades of that chronic high CO2 have blunted their respiratory center's sensitivity to it. They have come to rely, paradoxically, on the stimulus of low oxygen, their hypoxic drive, to keep breathing.
So if you give them high-flow oxygen,
If you give it indiscriminately, you can obliterate that drive. You can actually cause them to stop breathing entirely, which leads to severe hypercapnia and narcosis. So we have to titrate their oxygen to a much lower target saturation range of 88 to 92%.
but, and this is the clinical tightrope walk, you can never withhold oxygen completely if they are severely hypoxemic.
Never. You use controlled low-concentration devices like Venturi masks to stay inside that 88 to 92% window. And often, non-invasive ventilation, or NIV, is the life-saving bridge that takes over the work of breathing and helps clear that trapped CO2.
So the key takeaway on crisis management: unlike patients with acute severe asthma who look terrified and exhausted,
Severely decompensating COPD patients can look deceptively calm, maybe even a little drowsy.
and that's the danger of the CO2 narcosis.
It is. You must rely immediately on the blood gas analysis, not just how they look, to know how critically ill they are.
Okay, another check-in question. An 80-year-old COPD patient presents with severe shortness of breath and drowsiness. ABGs confirm type 2 respiratory failure. You immediately provide supplemental oxygen.
What is the specific target saturation range you must aim for? And what is the underlying physiological mechanism you are trying to avoid by carefully titrating that flow?
If you can clearly articulate the hypoxic drive and that 88 to 92% target, you have absolutely secured this critical safety anchor.
Right, let's turn our attention to the infections, the ones that present acutely and the ones that are more insidious.
Starting with community-acquired pneumonia, CAP.
CAP typically presents as an acute systemic illness. You see fever, rigors, those shaking chills, general malaise, and that often comes before the cough and the mucopurulent sputum even start.
And we absolutely have to remember the elderly here.
Yes, in a 75-year-old, the presentation can be so vague. Sometimes the only sign of a full-blown pneumonia is new onset confusion or delirium. You have to anchor that fact.
To manage and triage these patients, we have a non-negotiable tool.
The severity anchor, the C-your-OB65 score. This is a rapid checklist that basically dictates where the patient gets treated, at home, on the ward, or in the ICU.
Let's walk through the 5 components. C is for.
Confusion, defined by a mental test score of 8 or less.
U is for.
Urea, specifically over 7 millimole. It's a marker of systemic illness and often dehydration.
Oh.
Respiratory rate, over 30 breaths per minute, a clear sign of significant respiratory distress.
B.
Blood pressure, systolic less than 90, or diastolic less than 60. This is an indicator of septic shock.
And finally, 65.
For age, 65 years or older.
And the scoring is simple.
Very simple. A score of 0 or 1 is low risk. They can probably be managed at home with oral antibiotics. A score of 2 suggests intermediate risk. They need to be in the hospital.
And 3 or more.
3 or more is severe pneumonia, mandatory hospital admission, and you need to be actively considering an ICU assessment.
So the management principle is just speed.
Speed. Prompt administration of the right empirical antibiotics, guided by that severity score, is absolutely key to improving outcomes.
Okay, check-in question. A 75-year-old CAPI patient presents to the emergency department. She is confused, her respiratory rate is 34, and her blood pressure is 80/50.
Based on the CURB65 criteria, what is her minimum score, and what specific action does that score mandate regarding her site of care?
Tally those points carefully. That combination of signs puts her squarely in the severe category, demanding very urgent attention.
Okay, let's shift gears to tuberculosis, TB.
Caused by Mycobacterium tuberculosis, this is the classic example of an infection that just perfectly exploits the lung environment.
The pathogenesis is key. You get a primary infection, and the body usually walls it off into what's called a primary complex. This leads to latent TB.
But the anchor for reactivation is what's clinically important. Post-primary TB, the active disease, typically targets the lung apex, the very top of the lung.
And we have to ask, why the apex? What is the core physiological reason that location is so favored?
It's because MTB is a strictly aerobic organism.
It absolutely has to have high oxygen tension to thrive. And physiologically, the lung apices are the least perfused, but the best ventilated parts of the lung.
The zone of the highest VQ ratio?
Exactly, which means they offer the highest available oxygen concentration, making them the perfect little microenvironment for that dormant TB to reactivate and start multiplying.
Clinically, you need a high index of suspicion because the onset is so insidious. It develops over weeks or months, a sharp contrast to the acute presentation of CAP.
You have to look for that constitutional triad: unexplained fever, drenching night sweats, and significant unexplained weight loss.
And the cough might have blood-streaked sputum.
It might. And radiologically, you're looking for signs of active disease in those upper lobes. Opacification, consolidation, and especially cavitation.
Cavitation being those large air-filled pockets.
Which strongly suggests highly active and therefore transmissible disease.
Diagnosis follows a clear hierarchy.
It does. Presumptive diagnosis starts with direct microscopy of sputum smears, often using special stains like Ormain fluorescence to quickly find those acid-fast bacilli.
But a definitive diagnosis needs more.
Right. It relies on techniques that confirm the organism is alive or that its DNA is present. Culture is still the gold standard because it's so sensitive, but nucleic acid amplification tests, or NATNUDs, give you a much faster definitive diagnosis, which is critical for public health.
And the treatment logic is rigorous and multi-phase to stop resistance from developing.
It is. You have the intensive phase, with 4 drugs for 2 months to rapidly smash the bacterial load.
Isoniazid, rifampicin, pyrazinamide, ethambutol.
That's the one. And that's followed by the continuation phase, usually just isoniazid and rifampicin for another 4 months to mop up any remaining slower-growing bacteria.
So a total of 6 months usually?
Yes, and that multi-drug approach is essential. Even one positive smear is enough to start therapy immediately because of the public health threat.
Okay, let's focus on imaging and interstitial disease. Respiratory medicine is so dependent on high-quality imaging.
The picture often holds the key, especially in chronic structural diseases.
Let's just quickly integrate how the different tools relate to each other. The plain chest X-ray, the CXR.
That's your essential starting point. It's a low-resolution map, good for seeing gross consolidation in pneumonia, collapse, or pleural effusions.
Then when we need to look at blood flow, we step up.
To a CT pulmonary angiogram, a CTPA, that's the gold standard for diagnosing a pulmonary embolism, and it's largely replaced the older VQ scans.
And if we need to know how metabolically active a lesion is,
that's when you use a PT-CT. It uses FDG to quantify glucose metabolism. It's crucial for staging cancer, evaluating treatment response, and figuring out the malignancy risk of an incidental lung nodule.
But when we're talking about the fine structural details of the lung tissue itself, the parenchyma,
then you have to use high-resolution CT, HRCT. It's the absolute gold standard for diagnosing any of the diffuse parenchymal lung diseases, the DPLDs.
A common scenario where these tools come together is the incidental pulmonary nodule.
A little spot on the scan. And the assessment is purely risk-based.
So what are the key risk factors that push us towards thinking it's malignant?
Age, first of all. The risk goes up rapidly after 35. A smoking history, obviously.
Okay.
And then the appearance of the nodule itself.
What kind of appearance?
A nodule that's spiculated, that has sharp, irregular, spiky edges, is highly suspicious. On the other hand, nodules with benign patterns of calcification are often stable.
And you have to pay special attention to subsolid nodules.
Yes, because they can represent pre-invasive or early invasive adenocarcinoma, and they often require very careful serial CT surveillance.
Let's zoom in on a disease where the HRCT is basically definitive. Idiopathic pulmonary fibrosis, IPF.
The most common and most serious form of DPLD.
So what is it?
IPF is a progressive fibrosing interstitial pneumonia. We don't know what causes it. That's the idiopathic part. And it's uniquely associated with a specific radiological pattern called usual interstitial pneumonia, or UIP.
Clinically, it presents in older adults with progressive breathlessness and a persistent, dry, non-productive cough.
And importantly, unlike TB or an acute infection, constitutional symptoms like fever or night sweats are usually absent.
The diagnosis really hangs on those HRCT findings.
It does. The UIP pattern has very specific features. Patchy subpleural fibrosis or scarring, characteristic clustered cysts that we call honeycombing.
Like a honeycomb.
Exactly. And something called detraction bronchiectasis, where the scar tissue is contracting and physically pulling and distorting the walls of the small airways.
And the management here has shifted significantly in recent years. We now have antifibrotic agents.
We do, pirfenidone and nintedanib, but it's so important to understand what they do and don't do.
They don't reverse the scarring.
They do not. That damage is fixed. Their role is to reduce the rate of functional decline. We typically start them in patients with moderate lung function, and for a disease that progresses so quickly, even just slowing that decline is a huge clinical victory.
But the prognosis anchor remains pretty sobering.
It does. Despite these advances, the disease is ultimately fatal. Median survival, though it varies a lot, is still often quoted as being around 3 years from diagnosis.
Wow.
Death is usually from chronic respiratory failure or severe pulmonary hypertension.
So the key takeaway for IPF is that it's a relentlessly progressive fibrotic disease of unknown cause, identified by that UIP pattern on HRCT, the scarring, and the honeycombing.
And while we have antifibrotics, they only aim to slow the inevitable decline. They don't cure it.
All right, one last check-in question. A patient with a history of environmental exposure presents with progressive breathlessness, digital clubbing, and bilateral fine inspiratory crowls.
What is the specific HRCT finding, that unique pathological sign of advanced scarring that you would expect to see that confirms a diagnosis of idiopathic pulmonary fibrosis?
Think about that specific structural distortion caused by the fibrosis, the sign that looks like a honeycomb.
You've got it.
Okay, this has been a real academic sprint through some foundational concepts. Let's just briefly lock down the most important clinical differentiators we covered.
I think we really anchored the symptom presentation. You always have to rule out those chronic cough imposters, first gourd, post-nasal drip, ACE inhibitors.
And use variability versus progression to separate asthma from COPD.
Right. And we defined the significance of type 1, which is a VQ mismatch, versus type 2, of ventilation failure, respiratory failure, and the danger of that hypoxic drive in an acute on chronic COPD patient.
We also established those non-negotiable red flags. Clubbing demands a cancer workup.
And the CRB-65 score is your immediate triage tool for pneumonia.
And we understood why TB loves the apex and the crucial timeline for the anti-TB regimen.
And finally, that the diagnosis of DPLD really hinges on the structural detail you get from an HRCT, confirming patterns like UIP that lead to that grim but potentially manageable prognosis.
I think crucially, the sources continually emphasize how interconnected the body is.
Yes.
We saw that so clearly in COPD, where the systemic consequence of lung failure isn't just local. That peripheral edema, a sign we usually think of as heart failure,
Is often an indirect result of renal hypoxia and hypercapnia. The kidneys aren't getting enough oxygen, they hold on to salt and water, and that results in right heart strain, cor pulmonale.
And that systemic reach is exactly the clinician's challenge, isn't it?
It is. It's so easy to focus just on the chest, but the correct diagnosis often requires you to connect dots from outside the organ system you're examining. Lung cancer, for instance, is notorious for showing up via perineoplastic syndromes.
Endocrine or neurological problems that seem completely unrelated to the lungs.
Exactly. So you have to think about the implications. Understanding why a subtle change in a smoker's cough might signal a local tumor invasion, not just more bronchitis, or recognizing that a lung nodule's risk profile changes dramatically just based on the patient's age and smoking history.
So here's our final thought for you to carry forward.
When you encounter a patient with breathlessness or a cough, remember that the true test of your diagnostic skill isn't just in recognizing the textbook findings inside the chest, the wheeze, or the crackle.
It's about your meticulous ability to recognize and interpret the extrapulmonary signals.
The medication history, the presence of clubbing, the subtle signs of systemic compensation or renal dysfunction. These non-respiratory cues will often be what guides you to the correct and sometimes life-saving diagnosis.
Internalize these structured frameworks. They will save you time, anxiety, and potentially your patient's life in those clinical encounters ahead. That's a wrap on this deep dive.
We'll see you next time.